PA. I work here at Horn Family Practice, but in my other life, I do ER. I do a lot of ER, and that's kind of where my passion is. I was asked to teach you guys about sepsis and how we recognize it. So my job today is to teach you guys a little bit about sepsis. A big dilemma that a lot of emergency rooms struggle with is how to identify septic patients. Not only ERs, but also on the floor and for home health. When you go into a patient's home, you might be the only access to the medical field that they have. So you need to know how to identify when this patient is sick, when they need to be seen, or on the floor, when they need to be transferred, when you need to call their doctor, and in the ER, are these patients sick or not sick? The big problem is a lot of our patients come in and they just say, I'm sick. Well, can you tell me a little more about that? Nah, I'm just sick. Okay, so now we're at this point where we're coming into influenza season, and what are we going to do with them? They all look sick. So just get fluids and cultures for everyone, what do we do? A lot of you are like me, we got into medicine to save lives and to make a difference. And this is what we seem to be doing a lot of. Writing a note so they can go out and have a great day, right? That's what we seem to be doing a lot of. One problem that I have found is that we get a little jaded in the ER. We get a little jaded in medicine. But I want to tell you just a little bit about my last patient who told me, I'm sick. I'm going to call him Fred. He's a little bit different than this last patient. He came in and he said, I'm sick. The triage nurse said, tell me a little bit more. I'm sick. Checked him in, put him in a room, back in room 16. That's the hallway where you're not really sick. And he said, I'm sick. That's what he told his nurse, I'm sick. So she came out and she said, good luck. Good luck with 16. I'm sick. I'm sick. That's all he could get out of him. All right. So I looked at his vital signs, you guys. He was tachycardic. His heart rate was about 100. He had a little low-grade fever. His respiratories were about 22. All right. So now he's in the surge criteria.
How old is he?
60. We're going to say he's 60. I changed his name and his age a little bit. But he couldn't be marked for an infection because he wouldn't tell her anything. It was just, I'm sick. So now we're trying to dig. So I go in the room and eventually I get out of this guy, but he's got a bellyache. He can't poop. And he wants me to take him off his meds because he goes to the VA and he's got a list this long. He's been going to the VA for week after week after week for 6 months. Okay? But what he's telling me doesn't make sense. He's not really speaking right. So I get a really good history, because that's what we're taught to do, right? Get a really good history on these patients. So I'm trying to ask him basically if he's dumb without being rude. What's your education history, sir? Any IQ issues? He looks at me and says, I have 2 master's degrees. One in archaeology, one in anthropology. I just can't speak right, okay? Okay, I'm busy. I've got better things to do. I go sit down, I start putting orders in. Ah, dang it, I can't do that. I go back in. What do you mean you just can't speak right? I don't know, the words just haven't been coming out of my mouth right lately. But he's here for belly pain. Ah, all right. So I did what any good provider would do. That's my last sick patient's brain. We don't have to be a radiologist to know that this doesn't belong there. Fred had a glioblastoma that was missed for 6 months. And all I did was pay attention to how he was telling me, not what he was telling me, and his vital signs. Vital signs weren't quite right. So this makes all of us a little bit like that. A little bit like Dr. House here, guys. So really pay attention to those vital signs. Pay attention to what your patient is telling you and how they're telling it to you. A man with 2 master's degrees just wasn't talking quite right. What he was saying to me wasn't making sense. I thought he had a low IQ. I did x-ray his belly too, just so you guys know. I didn't ignore all of his complaints. So, what is sepsis? How are we going to get there? What are we talking about? If you look on Wikipedia, it's going to tell you, it's a whole body inflammatory response to an infection. What it really looks like is something like this.
Yeah.
Gabe calls me and says, Shell, I think slide number 8 didn't come across right. I said, no, Gabe, I was trying to be funny. So Sepsis is SIRS plus infection is sepsis, okay? SIRS plus infection is sepsis. How common is this? It's really common. Everybody, think of where you work. Think about how often do you see CHF? All the time. Every little old man, every little old woman has CHF. Look at severe sepsis, 300 per 100,000. CHF, 215. More common than CHF. That's a lot, you guys. It's more common than breast cancer, colon cancer, and AIDS all combined. The mortality. Now, the mortality of severe sepsis actually just surpassed acute MIs. I didn't have the exact number, so I didn't want to change it on here. But here, they're almost equal. The real number just came out. I don't have the exact number, but it is now higher than acute MI. So the mortality is super high. Now, I'm not going to switch to the next slide yet, because I want to ask a couple questions. Who works in the ER? Okay, Randy. What gets you going? What freaks you out in the ER the most? What comes in that makes you go, oh my gosh?
Probably acute MI.
Okay, ready? Okay, the mortality rate for acute MI, 2%. The mortality rate for septic shock, 30%. Severe sepsis, 25. That indeterminate range, 10 to 15%. Acute MI, STEMI, 2%. STEMI comes in, we're freaking out, you guys. We're the helicopters in the air. We're running around, our butts puckered up. We're freaking out, right? Code STEMI, cardiac alert. The whole hospital getting worked up. We all want to run to the ER and see what's going on. Look at the mortality rate. Look at the difference, you guys. That's huge. It just got real, didn't it? It just got real to you guys how important this is. It's common, it's expensive, it's frequently fatal. See, that guy just said, I told you I was sick. Yeah. Know the signs, know sepsis. Super important, you guys. So, definitions of SIRS. Systemic inflammatory response syndrome. Now, this is your body's natural response to any sort of badness. Doesn't necessarily mean infection. Any sort of badness is your body's natural response to this. It doesn't necessarily need to be an infection to have SIRS. So a lot of people come into the emergency room, they're going to have SIRS, they're going to test positive for SIRS. You're going to put them down that SIRS pathway, but they're going to end up going home because they're not septic. That's okay, you're going to find this. So here's a little chart for you. Okay, so here's the infection, here's SIRS, it's where the two, it's where the two overlap. That's where you're going to find the sepsis, okay? See the SIRS pathway here? The SIRS circle? All these little dots, those are all badness. Trauma, burns, pancreatitis, those can all have people. That's where you'd be glioblastoma, put that on your little SIRS circle. All those things can cause SIRS. And then over here, those are the infection that overlaps with the sepsis. That's where SIRS and infection overlap. That equals the sepsis. Now, SIRS criteria. SIRS criteria was initially developed on the Surviving Sepsis campaign. This was awesome. This caught a lot of sick people. I can get you guys all a copy of this too, so you don't have to write 100 miles an hour. This caught a lot of things, a lot of people's lives were saved by this, but they found that it took a little bit too much time to notify the doctor to notify people of the positive sepsis screen because we waited for labs. We don't have time to wait for labs. It takes too long. So, what they decided on the Surviving Sepsis was it was improvement, but it was too complicated. Delayed care. The transfusion, they used to call for blood transfusion on the Surviving Sepsis campaign, determined that was detrimental. That caused actual demise of patients. The central venous pressure was not a good indicator of fluids, and a lot of people couldn't do it. So that was no good for smaller hospitals. And debridement, they don't do that anymore. They don't use debridement. So Dr. Berg is a sepsis guru who has done over the last 15 years a modified SIRS criteria. This immediately screens patients as they come into triage. Nurses, this is what your front line is, this is where you come in. Home health ladies, pick nurses on the floor. This is how you guys can screen patients right there when you see them doing vital signs. Vital signs are so important in doing accurate vital signs. Respirators are always 16. No, really, they're not. Do an accurate respirations, guys, because that's super important. Just like you trust your dash on your car, you're going 65, you're going 65. Trust your vitals, do accurate vitals. The other one down here, guys, number 6, if a patient comes in from a nursing home, they're normally altered, you can't use number 6. It's only new altered levels of consciousness, okay? Now, going back, so to get onto a positive screening, they have to have 2 or more of the SIRS criteria. So 2 or more of those vital signs positive, plus you have to think that they have a potential infection, okay? These are potential infections. If they come in with something of this complaint, remember my little man, picture my little man in your head. CNS complaint, headache, stiff neck, okay? Respiratory, cough. Urinary, dysuria, frequency, urgency. Joints. Now this doesn't mean I fell and hurt my knee. This is a monoarticular joint pain with redness, swelling, heat, okay? Soft tissue, think of cellulitis, abscesses, things like that. Intra-abdominal, obviously, belly pain, fever. Rectal, vaginal, this would be rectal pain, vaginal pain with purulent discharge, those types of things. And then rigors and fever. Think of my little man, picture him in your head, and those go along with the vital signs. The modified SIRS criteria allows for early diagnostic labs to be drawn, enter the sepsis pathway from triage, or for you who are at home or on the floor, you are able to do this right there at the bedside. You are able to do their vital signs and you can put them down the pathway. You're able to get their labs drawn right away, get their lactic acid back right away. IVs are established and you can get IVs started right away. Now, this is the pathway you have right in front of you. Don't let it scare you. Basically, the nurse's job stops right above the lactic acid results. At that point, a provider is going to take over. You're going to see that they're going down that pathway. They've had 2 positive SIRS results and a suspected infection. You're going to have, hopefully, I think that we're going to get the med staff to approve that a sepsis panel is going to be a standing order. You're going to call your provider. And then providers will take over from there for fluid resuscitation and such. We will talk about MAP in a minute. But that's kind of where, from the lactate and above, is kind of the nursing responsibility. Don't get too overwhelmed by the lower part, but I wanted you guys to be able to see this up close since this is so small, okay? Now remember, sepsis is SIRS plus infection. Now let's talk about MAP and lactic acid. I will use lactic acid and lactate interchangeably, so don't let me confuse you there. These are 2 very important keys in determining the badness of your patient. Those are the 2 most important keys. MAP is going to be the first thing you look at, and then lactic acid. I will talk to you about MAP here in a second. We really didn't look at MAP before. It was never something we thought about, calculated. We just looked, oh, their blood pressure is really low. Crap, give them some fluids. Now we have a number, a concrete number, a calculation to look at, you guys. Mean arterial pressure. Now, I am no mathematician. I don't expect you guys to be a mathematician. There are calculators to do this. There are apps on your phone to do this. You plug it in. Don't be a hero. Don't expect to do this in your head on a piece of paper. Download an app. Go to mdcalc.com. Use something to figure this out, but you need to know how to do this. This is the difference between calling the helicopter or tucking him in on the floor. This is vital, okay? Example, my blood pressure is 90/60 on a good day. My MAP is 70. It's not going to take much for me to be sick, and you're going to have to call a helicopter because I don't have much reserve. So when you're calculating a MAP, you stay on top of it. Know how to do this, you guys. Really important. MAP less than 65, badness. Know this number. Less than 65, your patient is sick. It's an urgent patient. They're going to require aggressive resuscitation. The diagnostics are initiated. They're going to immediately get 2 liters of LR. I mean, this is 2 liters pushed in, bam. Doesn't matter their CHF, it doesn't matter anything about them. If their MAP is less than 65, they're getting 2 liters, period. Okay? There's no question about that. They get 2 liters. If the MAP does not improve after their 2 liters, septic shock. Helicopters in the air. This is a bad patient. This patient has a high mortality rate. Super sick, 30%. This is far worse than the STEMI patient. butt pucker. Everyone should be running around, okay? Super sick patient, Randy.
And the IV is lactate rare.
Yeah, yep. They recommend crystalloid, but LR is the biggest fluid expander. That's what they recommend is the best.
Okay.
What is lactic acid? Holy cow, we can get lactic acid pretty soon, you guys. This is awesome. I've been trying for 2 years, now we can get it. So, we used to not be able to get it. It took like a week for us to get lactic acid. So a month ago, I presented to med staff. I made a proposal that we have this sepsis panel to include a staff lactic acid. Yay! We get it now. So I think it's next month, starting next month, we are able to get a stat lactic acid, and we are going to use the heck out of it. Everybody is going to use this, okay? This is important. Besides MAP, this is the next indicator of vagus. All of the studies have shown that our gestalt sucks when it comes to knowing how sick a patient is going to be when they need to be transferred. The magic number is 4. When your lactic acid is right around that magic number of 4, they need to go. They have to get out of here. They need an ICU at 4, okay? So lactic acid is a serum marker. It's when the body experiences inadequate tissue perfusion, it undergoes anaerobic metabolism. That causes a rise in the lactic acid. That means they're sick. There are a few things that are the badness that causes this is trauma, severe sepsis, shock, tissue hypoxia. An example of tissue hypoxia would be ischemic bowel. That would be one thing that causes the lactic acid for that. Other causes, so this is something that would happen that would cause it to be elevated that's not pure badness. It would just be a chronic elevation for vigorous physical activity, seizures, a person who's on beta agonist, or chronic liver disease. So for instance, let's say Beltry's out running 100 miles and he twists his ankle. He comes in, we do an x-ray for some unknown reason, we check his lactic acid. It's going to be elevated. Do not fly him out of here in a helicopter. He's going to be really angry at us. Okay? Don't fly him out. It's going to be elevated, and it's going to go down. So, but a person in chronic liver disease or on beta agonist, they're just going to be elevated, stay elevated. Okay? Those people are okay. They're not going to be blown out. Those are the people who are going to have it elevated, and it's going to be all right. Okay? Why do we get lactic acid? This is going to tell us sick versus not sick. This is going to tell us the level of care. Do we keep them here? Do we ship them out by a basic squad? Do we call the helicopter? This is super important. Another thing that's really important is serial lactate. This tells us the response to the therapy that we're giving them. Lactic acid has a super short half-life, 20 minutes. So we give them 2 liters of fluid, we recheck their lactic acid that quick. It's going to either go down or it's going to go up. It's going to stay the same. That's going to tell us whether or not we're doing our job here, if they can stay or leave. Treatments and pathways here. This is the easiest one. These people are easy. Whew. Uncomplicated sepsis. This just basically means they have SIRS plus an infection, but everything else is normal. Normal MAP, normal lactic acid. They gotta go home. We just give them some antibiotics, send them back home. Whew. That was easy enough, right? We like that one. Sepsis. Now, so we got uncomplicated sepsis, now we have regular sepsis, okay? These people are SIRS positive, plus your infection, plus a lactic acid, somewhere between 2 and 3.9, okay? Now your providers here, they're involved. Here's your little pathway. Now your pathway's in front of you. They're gonna get your 2 liters, because everybody gets 2 liters. You're gonna get cultures, antibiotics, you're gonna culture whatever you think is infected. So let's say it's they've got a wound, let's say they've got urine, they've got cough, you're going to culture whatever site it is, plus their blood. You're going to give them fluids, you're going to give them antibiotics. You're going to recheck their lactate after their fluids. If their lactate has cleared more than 10%, great, you're going to stick them on the floor. If their lactate has not cleared, lactate clearance is considered to be decreased of at least 10%. After 2 liters, they have to go to an ICU. If their lactate has not gone down 10% after 2 liters, this is a sick patient. They have to go to an ICU. You give them an additional 1 liter of fluid, they go to an ICU. Let me tell you about that. A persistently elevated lactic acid means they are still producing lactic acid. This means they are still sick, they are still going down the tubes on you. Dr. Berg's analysis after 15 years shows that in hospital mortality rate greater than 50% on these patients. This is not a patient I want here at Horn in the middle of the night. Do you guys? I know Ruth Ann doesn't. She told me.
She'd tell ya.
She told me. So we want these patients out. We want to recheck that lactic acid after the first 2 liters. Super important. Severe sepsis. They're getting sicker and sicker. So we started the good ones. They're just getting worse. This guy's really sick. He doesn't look so good. Severe sepsis. SIRS plus infection plus the lactic acid greater than 4. Remember I said that 4? That's the magic number. We don't like him. We want him gone. So he's had that 2 initial liters like we talked about. Everybody gets that 2. Impaired fluid loading. Check out your flow sheet there. Go to the impaired fluid loading. You're already getting your blood cultures, your culture of whatever's infected, and you're going to get them out of here. You start your antibiotics, you're going to get them out of here. They're not staying here. Not with lactic acid of 4. Septic shock. We already talked about this too. SIRS plus infection plus a MAP less than 65 after your first 2 liters of fluid. This is when the bird's in the air, septic shock is bad, MAP less than 65, bird is in the air. The treatment pathway for septic shock is pretty gruesome. It's a lot of running. So you got your fluids, your labs, your cultures drawn immediately after your MAP is found to be 65 because you're such diligent, awesome nurses. You found that immediately right when they checked in. So you're getting going, you're running, you're getting all that stuff taken care of. Now central line, if you're capable, I don't think we do central lines here, right? So you got 2 peripheral IVs started. You're pouring your fluids in. Your provider's going to come in. They're going to start norepinephrine to keep that MAP above 65. The helicopter's already in the air. And this is what you're doing. I'm pretty sure that's not ketchup and mustard. At first I thought it was. I think those are blood cultures in his hands. I kind of was like ketchup and mustard, like you're eating a hot dog while you're running. But no, that's what you're going to be doing. Sort of like Randy when there's a stem coming in, right? So, again, back to the fluids. Everyone with sepsis gets it. With sepsis or higher, not uncomplicated sepsis, but sepsis or higher, 2 liters of fluid. The uncomplicated sepsis, if the provider thinks they need fluids or whatever, that's fine. Important curls. Back to the 2 major branching points, your MAP, your lactic acid. Those are the 2 things you're going to be looking at most. MAP less than 65, aggressive resuscitation, diagnostics, 2 liters, recheck. Remember, that less than 10% clearance on the lactic acid, bad news. Lactic acid, if the MAP is greater than 65, then your lactic acid is your next diagnostic point. And again, what about those influenza patients? What are you going to do about all those guys? Yeah, they're going to get screened, probably, because they're going to look sick. They're going to make it down that pathway. But likely, you're going to have a negative lactic acid. You're going to have a positive influenza. More than likely, they're going to end up just going home. But the provider will kind of tease that one out. You're going to put them down the pathway, but it's better to screen more and have extra that you're screening than to send them home without screening them. That's totally fine. What does this change? Why are we doing this? This is important because 1, it's decreasing mortality rate. We are saving lives, and that is why we went into this. I added a slide, it's not in there. It takes 6 patients to treat to save 1 life. That is awesome. There's no other thing in medicine that we can treat 6 patients and save a life. So that's amazing. So think about that, 6 septic patients and you saved a life. That's huge. That's one of the few things in medicine that we can do 6 patients and save 1 life. So this is awesome. And that happens in 1 month. We've already saved 1 life because we see sepsis so often. So that's really awesome. So we're decreasing mortality. We're decreasing the length of stay because we're recognizing it earlier, we're treating it faster. This one's for you, Ruth. So, increased ICU admissions. Now let me explain why this is. Because we're now, instead of going from the emergency room to the floor, then they're crumping, then they're going to into the ICU, we're recognizing it immediately and we're going straight from the ED to the ICU. Before, we've been sticking them on the floor because we weren't recognizing sepsis. Now we're recognizing it, realizing how sick they are, and then they're going straight to the ICU instead of crumping on the floor in the middle of the night, the nurse is having to deal with it on the floor, and then going in the middle of the night to the ICU. So this is preventing and changing that. So that is the increase in the ICU admissions. Improved reimbursement. That's a good one, because instead of labeling these patients UTI, pneumonia, we're now labeling them as sepsis, severe sepsis, septic shock, and that is increasing our reimbursement. The take home on all this, not all SIRS equals sepsis. We have to tease that out, we have to figure it out, but putting them down the SIRS pathway really helps us get there. Sepsis is common and frequently fatal. I can't stress enough the fatality and the mortality rate of that. MAP less than 65, badness. MAP is your friend, learn MAP. Be like Dora, put it in your backpack. MAP is your friend, okay guys? You can be septic with a normal lactic acid. That's the uncomplicated sepsis, know that. Early recognition, fluid, antibiotics, and the nursing staff knowing their vitals is key to survival. Any questions? None? Oh, come on, there's gonna be lots of questions.
You did such a good
You
job.
did
There
a
is
great
no
job.
job.
That's awesome.
So all our ER doctors will be made aware of this?
So my plan is to present this to med staff and make this kind of a standing protocol.
Yes.
Okay.
There will be kind of an order set that'll be changed in the ER to order the sepsis panel that has been approved by med staff. For you guys to do that, there'll be some changes in the documentation down there for you to identify these patients and get them going through this path.
And we'll be working with the ID to make sure that
And
that's.
yeah, we'll have a protocol for you guys to pull, it'll all be there. We're kind of in limbo waiting for those lactic acids to come in-house, so we'll have all of that done before that happens.
I got the sepsis panel approved by med staff last month, but about a week ago, I came up with this pathway right before I presented, so I haven't had a chance to present this pathway to them yet. But it's a really awesome pathway, it really gets things recognized immediately and gets the patients down the pathway quickly and gets the fluid resuscitation. And yes, I know that little card handout is wrong. Yeah, they have to fix that.
How long does it take for the lactic acid to come back once it's sent to the lab?
It should be a stat lab, I mean, within 15, 20 minutes. And down in Winterset and Sioux City, I get it back within, in Winterset it's faster actually, about 15, 20 minutes. Sioux City,
The only reason I asked is because my son recently was in ER up in Sioux City because they thought he had a strangulated hernia.
oh yes.
And, yeah, it took a little longer than that. I was just about livid. But anyway, that explains why they did the lactic acid. I'm sitting there going, what the heck is lactic acid and why are they doing it?
See, yep, exactly, because it identifies badness and if he was going down the bad pathway.
You got to go home.
That means his lactic acid must have been good.
That means he had to have surgery done too.
Yeah,
So the LR is being run as a bolus?
yes, yep, and they recommended over 20 minutes.
The 2 liters or the 1?
Each liter over 20 minutes. And there was another, I kept changing it, I think I sent it to Port Dave like 3 different times. Basically, if your ejection fraction is greater than 40, you get a total of 4 liters over 6 hours. If your ejection fraction is less than 40, you get a total of 3 liters over 6 hours, but everybody gets that first 2 liters.
And for the most part, those 4-liter patients are not going to feel it.
Exactly,
They're
the
going to
bird's
be
gonna be
elsewhere.
here. Yeah, everybody's gonna get those first 2, and probably everybody's gonna get this 3rd one started
So the first 2 how soon?
fast, as fast as you can get them, basically.
Is there a standard antibiotic, or is it gonna be the antibiotic of choice?
It will be, we're gonna come up with a protocol, basically based on the site of infection. I'm gonna try to get pharmacy to get a local resistant rate. So based on our geographical location and geographic resistance, it'll be based off of that as well. So if it's a soft tissue infection and they know they have a high rate of resistance for Keflex, we will likely go with vancomycin, something that's locally susceptible.
And that would be
Makes sense.
something that we'll have here available in the protocol, all broke out.
Yep.
And they'll probably be laminated because
Alternative.
yes.
And I'm hoping that the EMR will also, once the vital signs are plugged in, it's going to flag you, SIRS, and then as you guys as providers will go, oh, they checked in with belly pain, they're flagging it SIRS, oh, they're gonna go down the pathway, you immediately put them in the pathway. So I'm not sure who's in charge of talking to the EMR people.
Showcase.
Perfect.
Would be the church.
Have other hospitals enacted this particular pathway also already?
Yeah, that's where I got it from. One of the, several hospitals up in Minneapolis, Dr. Berg, Cameron Berg implemented this at a few different hospitals up in Minneapolis. And they've seen a decrease in mortality rate by about 5%, and there's been several, obviously, the changes, the increased ICU admission, the decreased mortality rate, the increase in reimbursement, those came from his studies based off of the implementation of this pathway. I was actually hoping to pick his brain prior to giving this, but this is all based off of his presentations. He was calling me tomorrow. Yeah. Yes.
So how long does the process take? Say if they come in, they're really sick, they're critical, how long have they been sick? Or does
It just depends. Depends on what they're sick with. All of it can happen over hours. It can happen over days, depending on what the infection is. Yeah, lactic acid can elevate really quickly. Like for instance, she said her son potentially had an incarcerated hernia. If that had been incarcerated and it turned ischemic, his lactic acid could have been high really quickly. Because ischemic bowel can cause lactic acid to go high quick.
What is the target time for, like getting them out of our ER?
As soon as you identify them, especially like the MAP less than 65, once they don't respond to that initial 2 liters, call. Yep. And then once you identify that their lactic acid is greater than 4, call to start the transfer process, those types of things.
So say I'm doing a home health visit and this person is, they say, oh, maybe it's somebody we only see once a week. And they say, oh, I've really been sick the last 2 or 3 days, and you can maybe pinpoint maybe 3 of those. Would you just say you need to go to the ER, or just call the doctor, say you want to see him in the office?
So you're pinpointing 2 or 3 of the search criteria, and then if they have a complaint of an infection that meets my little man, then I would probably call their provider, see if their provider can get them in. If they can't, then have them come to the emergency room. If you take their blood pressure and their MAP is less than 65, call the ambulance, have them come in. Yep. Good question. Very good question. Yeah, especially, gosh, you home health girls, I mean, you're their only access most of the time. That's why it's really important for you guys to know this stuff. Yeah.
And age doesn't affect lactic acid?
Age does not affect it.
To do with
I
that?
find that the older you get, the more beta agonists you're on though. So watch those beta agonists. They use them occasionally. They're not like twice a day, every day. And I find that the beta agonist doesn't necessarily cause it to go up as much as the other ones. But if they're acutely ill and their lactic acid are elevated, we're going with it, it's elevated. Not that, if they look good and their lactic acid is elevated and they're on the beta agonist, probably it's the beta agonist. But if they look bad, they're probably sick. And that's when you kind of have to use your gestalt on that, your experience with that one. Good question. Anybody else? Good questions, you guys. Now you guys are all experts. Okay, so Roseanne, did that make you feel better?
Yes.
Good.
We want you to feel good.
Well, she was worried.
I like to feel good.
And this really does. I mean, she was worried about patients that crump on the floor, and she was hoping that this would increase their transfer prior to hitting the floor, and I think that it was really going to do that. It's going to catch those patients because we are bad at picking up patients that are sicker than we think they are, and this is going to help do that. And this
Or they'll
is,
say, well, let's put them to the floor overnight and see what happens.
yeah, and this is
Why
going
do
to
we have to
prevent,
see what happens?
yeah, why wait until they crump? And I think this is gonna prevent them from crumping on the floor. It's gonna get them there before they crump.
You're
Yep.
still gonna have to get the doctors on board though, the other ones.
Well, I don't think they're gonna have much of a choice if we make a standing order.
I was gonna say, our medical staff was ready to roll with it. They were
Oh,
all about it.
the minute I
So,
presented it, it
our doctors
passed.
didn't have a problem.
Yeah, we are not.
And the ER docs will have to do some education with the PD, but I'm sure they're working on this everywhere, because also, this is part of the Partnership for Patients campaign, the 2.0 that's coming out. So every hospital in the state of
Has to-
Iowa is
Basically
mandated
moving to this.
work on this. So if area hospitals aren't doing it, they will be.
Yeah, I think this is kind of everybody's moving towards this. We're just one step ahead of it because I work at so many hospitals that just know about it.
I was gonna say, Michelle got us on board right away, we're like on the cutting edge.
Yeah, and that's one good thing about working at other hospitals, you kind of see what everybody's doing and then you can kind of bring it back into other hospitals, you know, it's great. So, okay, now we're gonna talk about skin tears.
Just need to cheat sheet.
How do we make those on the side of the way?
If you go up to slideshow at the top,
Right or left?
all just like all the way straight up.
Kind of straight up in the middle.
Oh, got it.
And then just hit from the beginning all the way to the left. No.
I'm technically challenged.
That's you. Very
Okay, skin tears is not nearly as sexy of a topic as sepsis. So, it is very important, you're exactly right. It's very, very important. So I'm gonna try to be as excited about this as I was about sepsis, okay guys? So let's talk about skin tears. What are skin tears? It's basically when it's a traumatic injury that causes a tear of the skin. It's typically when the outer layer and the inner layer separate, or if it's a full skin thickness tear, it's when both layers separate from the underlying structures, okay? Skin tears, who cares? That's what a lot of people think. However, these are really important. Everybody thinks, that everybody gets them. You're right, everybody does get them. So that's why we've got to work hard to treat them, but most of all, prevent them. A lot of times they might appear minor, however, they're complicated by underlying infection, impaired blood flow, and comorbidities. The underlying impaired blood flow is what's really I struggle with. These are the ones I see in the patient or in my office a lot. This guy here, it's hard to see for you guys, but he's got big time chronic venous insufficiency, venous stasis. He might even have a little bit of arterial insufficiency as well. If he gets a skin tear right here, that thing's not going to heal. I'm going to see him down in the office and we're going to struggle for months to heal that thing. So this is really important. Adults typically get them on their upper extremities, their lower extremities, and on the dorsum of their hand. Can you guys see this okay? Should we shut down the light? So we want to hit maybe this right back here. Is that better? Okay. So this is a skin tear on the elbow, full skin flap loss. Now on neonates, yep, I said neonates, these guys get skin tears as well. We don't get a ton of them here, but we still do, and some of you home health people can even see neonates as well. They typically have them on their head, face, and extremities. Usually they're from adhesive or from devices on the outside hitting them as well. Who are at risk? Typically the extreme ages, the very old, the very young, and those who are dependent on other people. What do these people look like? What are you looking for? Who do you see when you see skin tears? You are seeing people with dry, fragile skin. They usually have a history of skin tears. They're those people with those big brown spots on their arm, and you're like, boy, that skin's just waiting to tear off. I can see it now. They're usually on medications such as steroids or blood thinners. Poor nutrition and hydration. They usually have some sort of a sensory or cognitive impairment, diabetes, any type of neuropathy, either whether from medication or just the diabetic neuropathy. And they usually have some sort of a slide to the thing. Comorbidities such as diabetes, chronic venous insufficiency, heart disease, or kidney disease. The bottom line, look at your patient, look at their skin, look at their underlying conditions, and look at their overall condition of where they're at. Look at their home, look at their hospital room, look at the patient, look at their skin. These are what the at-risk patients look like. You know that, you know what they look like. Also, don't forget about excessive weight loss patients. They've got that really loose, thin skin, it's just hanging. Those patients are really at risk for shearing and skin loss there. Everyone shook a hand like that. We all shake those hands and we're like, oh, I don't want to hurt you, I don't want to tear that skin off. Everyone has seen that bottom, haven't we? We all know that bottom. Now, I want to talk about that bottom real quick. Be careful on the commodes, guys. That bottom, don't scooch them off the commode. It's going to just tear that skin right off. You want to make sure that skin is hydrated, and you want to come straight up off the commode. That bottom is going to slice right up, it's going to tear that skin right off. Be careful of those bottoms. Skin tears occur from intrinsic and extrinsic causes. Some of the intrinsic causes, we age. Sadly, we age. We lose the collagen and elastin in our skin. It flattens, it wrinkles. It gets dry, and the large vessels and the small vessels also causes a lot of problems with skin tears. Now the neonates, here's why. The neonates do not get full thickness of an adult skin until long after birth. Usually at the time of full term, it's only 60% of the thickness of an adult skin. So they're still, even by the time they go home, even if they're born full term, they're only at 60% thickness. So imagine how thin that skin still is. So they're at high risk. Extrinsic. These people are in need for assistance, like the ADLs, bathing, showers, transfers. That's what looks pretty dangerous to me. Those people are at risk, you guys. You gotta be real careful with them. People who are on medication and have poor nutrition and hydration, those people are at risk. Those are the extrinsic factors. Now, assessment. You want to look at their general health status, comorbidities, and what healing potential do they have. Know when, where, and how. Now, there's a whole lot of stuff here. But the documentation is obviously the most important for everybody. On the floor, home health. Home health, you guys probably see a lot of skin tears. You're not probably going to know how it happened, but you can document the rest. You want to especially get the length, width, and the depth is really difficult on skin tears. I mean, you can't really measure the depth of a skin tear unless it's significant. But make sure you get the width and the length and width. Make sure you try to get the amount of bleeding and the hematomas. Hematomas have to be evacuated, you guys. You cannot leave a big, huge hematoma in there. You've got to get that out of there. Integrity of the surrounding skin is important. If the flap has necrosis, if the flap is dusky, if it's purple, make sure you talk about it. Say, we may lose that flap. It appeared to be dusky. It appeared to be necrotic. So make sure you document that way. If it doesn't turn out well, it's not your fault. You said it was dusky. We might lose it. It doesn't look good. But you did try to reapproximate it. Make sure you talk about associated signs and symptoms of infection and pain. Okay, those are important things to get too. Now, there used to be 2 different types of classification systems for skin tears. Did you guys know that? I didn't know that. Nobody uses them. We all know about the documentation of pressure ulcers. Who knew they had some for skin tears? So they did a study. 5% of people used one of them and 10% used the other. Yeah, that's why we didn't know about it. So the International Skin Tear Advisory Panel has now come up with a new one to try to make a universal language for skin tears. So this is what we're supposed to start using, okay? Type 1, Type 2, and Type 3. So this is what I'm proposing that we all kind of start using. This is the newest suggestion to start classifying skin tears. They really broke it down and made it a lot easier for us, super easy. Type 1 is there's no skin loss. It's either just a straight cut or a flap that's completely able to reapproximate. So the whole flap can go right back where it left. Great, that's Type 1. Type 2, there is a flap, but the part of it's gone. So there's a flap, but a piece of it's missing. Great, that's Type 2. Type 3, the whole flap's gone. Whew. That's pretty easy. We can do that, right, guys? So 1, no flap's missing. 2, part of the flap's missing. 3, whole flap's gone. We can do that. That's easy enough. And here is what it looks like. This is their little thing that they send out. Type 1, Type 2, Type 3. And those are pictures of examples of the wounds, of the skin tears, okay? Treatment. Obviously, if you happen to be right next to the patient and they get a skin tear and they're bleeding, you want to put pressure on it and elevate. You want to stop the bleeding, okay? If you're not there, the next thing you're going to do is you're going to clean the wound with a product that is not detrimental to the wound. So normal saline, or here at Horn, our standard protocol is Pronto-San. And we're gonna keep that in our protocol because it is good for the wound. Pronto-San is what we typically use. You're going to approximate the skin flap. This is super important, you guys. It needs to be moist. The skin flap needs to be moist. If it's dried out at all, set the moistened gauze on there, let it sit for a few minutes. You're going to be an artist. You have to put this thing back together, okay? The skin flap itself is the best bandage you can give the patient. So don't like, that looks really hard, I don't have time, just cut it off. No. Take your time, use either a moistened Q-tip, get out some forceps and some wet gauze, sit down, and you're going to unfold that thing as gently and as moistly as possible and put it back on there. Super important. Select your appropriate dressings. Now, the one thing we're going to change in our protocol that we currently have is they're saying that steroid strips are okay now for the partial or the full skin flap that's still remaining. Just the big thing is make sure you leave a little bit of gap in between your steroid strips to allow for drainage to come out. We're going to leave it in place for several days and mark it with an arrow. Now, this confused some people. The arrow, so let's say that's going to be your bandage, the arrow is going to point this way because you want the next person to lift this side of the bandage and take it off that way. You don't want to pick up this side and go that way, do you? The whole flap will come off, right? So we want to make sure you draw your arrow this way, and we want everybody to know, oh, when I go to take it off, I'm going to lift it up and take it off this way, because we don't want to disrupt that flap. Super important. The wording is kind of confusing, and people are like, arrow, I don't understand. That's what we mean, okay? Dressing selection. There's several reasons we want to pick our dressing. We want it to be easy to apply. We want to prevent any shearing of the wound. We want to keep the wound moist. The best wound healing is moist wound healing, okay? We want it to be flexible. We want to wear it for a long time. We don't want it 3 times a day. 1, the patient don't want that. 2, you nurses don't want to do that. So extended wear time, super important. Atraumatic removal. We don't want adhesive on these patients. We don't want more skin tears. Silicone is very safe, very comfortable. That's why we're going to stick with the Meplex border. Cost effective. We don't want to cost home health a bunch of money. We don't want to cost the hospital a bunch of money. We don't want to cost the patient a bunch of money. So there's a fine line there because, of course, wet to dry is super cheap, but it's not convenient, it doesn't work. So there's a fine line of choosing that one. And optimizes the quality of life. That's a big thing for the patients, you guys. We have to find what works best for the patient as well. For instance, Alginate Zero from Gauze, Meplex, those are 3 really good quality products. Don't use tape. Don't ever use tape if you can. And if you have to use any sort of adhesive at all, even like the Meplex border, you've got to use Skin Prep. Skin Prep is your friend, okay? So this is a skin tear decision algorithm from the International Skin Tear Advisory Panel. Basically goes through everything we just went through, all the way from skin tears, assessment, cleanse, approximate the edges, goals of treatment, and your types of wounds. Pain. Let's talk about the pain. Treat their pain, but remember, if they're complaining of throbbing pain, the only thing that's going to treat throbbing is elevation. A pain pill isn't going to help. Ice isn't going to help. Heat isn't going to help. Elevation is the only thing that's going to treat throbbing pain. But don't forget, increasing pain, look for infection. A lot of times, increasing pain means infection, so look for signs and symptoms of infection at that time. When are you going to ask for help? When are you going to say, I don't think this is something I'm going to mess with. I need their doctor or their provider to see this. Extensive full skin thickness or just an extensive skin tear in general. I had one the other day to come into the ER. It's actually a girl who graduated with mom. So I was extra nervous. I'm like, great, I gotta take really good care of this lady. She had been on Coumadin, chronic steroids. She had lost 100 pounds as an adult, and she had hit it on this beach chair. The whole front of her shin had been avulsed. It was down through the subcutaneous tissue to the muscle, and it was like, so it was a skin tear laceration. It was the thinnest skin I have ever seen in my life, and it needed sutures. Well, how do you suture skin like that? It took me over an hour. It took 38 sutures and like 12 steri strips. I was actually suturing through the steri strips, trying to get, oh my gosh, it was a nightmare, a nightmare. Big hematomas, if you have a big hematoma that's formed underneath of there, have the provider see them, because that whole thing's gonna have to be evacuated, okay? Now, prevention, guys. Prevention is obviously better than a cure. This is where we can really make a difference, knowing what's going on around the patient. Don't you wish we could do that sometimes? That's what I'd like to do. Except we gotta cover the doors with our hands, that's kind of important too. So, adequate lighting. Make sure that you can see, make sure the patients can see. Because heck, sometimes you can't see even if there is adequate lighting. So you wanna make sure their furniture, one, try to keep it as minimal as possible and make sure there's around the edges, nothing in the middle. Rugs, get rid of rugs. Home health people, check out their houses. See if there's little rugs laying around, get rid of them. That's just a danger.
Yeah.
You should take them away.
Explain to them why I don't like just being a rug napper.
Right there.
All of our home health nurses are gonna go to jail because we don't steal their rugs.
Take them up and put it there.
Pad the corners of sharp objects, you guys. Make sure you're using enough people to transfer and use transfer aids when possible. Make sure you're using a slide sheet, not the bed sheets to transfer patients, really important. Good nutrition and hydration. This is one thing that's really big about keeping the patient's skin integrity. Use the dietary aids, the dietitians if you can. That's gonna be really important to get good nutrition and hydration. Have your floor aides go around making sure their water cups are filled up at all times. Make sure they're not drinking iced tea and coffee all day long. Make sure they're getting water. Tricks of the trade. I don't know, what are we using for soap on the floor? Are we using like a pH balanced, no rinse soap? They recommend like a special pH balanced, no rinse soap for skin hydration. That's one thing they recommend. Another thing too is creams instead of lotion. A really smart dermatologist once told me, don't ever put lotion on your skin. You might as well just dip yourself in a tank of water. That's how good it is for your skin. Creams, not lotions. Yep, so the type you scoop, real thick emollient stuff rather than a lotion. Control moisture for incontinence. Skin prep everything. Anytime you're gonna stick anything on their skin prep it. If anything is stuck on their skin, use an adhesive remover. Make sure everybody knows that aides, everybody that texts, don't just tear something off of their skin. You're going to make it worse. Be mindful of their peripheral devices. And my slide is missing something. I don't know what my last one was. Now, talking about you guys. Keep your fingernails trimmed. We all like to have our fingernails look really pretty. It doesn't work very good for the floor. Now I know you guys all rock these at home, don't you? Randy, you got a pair of those?
I know.
So, jewelry. We don't want a bunch of jewelry at work because that causes a lot of skin tears. Take care when transferring patients. I don't know what happened to my little slides here. Now, this is completely off topic. However, this is another thing to think about when you're looking at patients. You're assessing their skin. You're looking at the whole entire patient. This is your chance to save a life too. When you're looking at their skin, do you see anything pop out at you? You're like, I just don't think that looks right. Look at their whole body, look at their whole skin. You might find a melanoma on them. So I'm just gonna give you a quick little input on melanoma too. Melanoma is something that just doesn't look quite right. The A, B, C, D, E's of melanoma, they're asymmetrical, they have irregular borders, their color, they've got more than one color mixed in there. Their diameter is bigger than 6 millimeters. Now 6 millimeters is the head of an eraser off of the pencil, okay? Evolving, you won't really know if they're evolving because you don't maybe know the patient very well. You might not have ever seen the lesion, but the rest you're gonna see. These things can occur anywhere in the body. So these patients can't see their backside. You're gonna see it. If you see something that doesn't look right, doesn't seem like it should be there, just notify the provider. It could save their life. It might be a melanoma. It might be another type of cancer that you could potentially notify the provider of. Let us know. Today's the day you might save a limb. You can make a difference with these skin tears, you guys. One, if you prevent them, that's awesome. Two, if you can get them in and get them changed and treated right away, you potentially could save their limb. I have personally seen people lose their limbs because of a skin tear. They're diabetic, they have poor arterial flow. These people actually lose their limbs. Not to mention their quality of life. Having to have a dressing changed twice a week, not being able to shower. I don't let these guys shower, you guys. If they have a wound, I don't let them shower. They can't get that wound wet Because every germ from the tip of their head to the top of that wound, the bacteria flows right through it. I don't let them shower. Talk about bad quality of life, right? So we need to prevent these patients from getting these, okay? So the take home, ID the risks, the prevention is key. Make sure you know their dangers in their environment, try to prevent them. Hydration and nutrition is a vital role in prevention of these wounds and healing too. Don't forget, hydration and nutrition help heal wounds as well. Beware of shearing and friction. Don't scoot your patients, pick them up and move them. And adhesives are the devil. Any questions? I don't recommend Googling old naked wrinkled people. Don't recommend it at all. You cannot unsee that. You cannot unsee what comes up when you Google that. Any questions, can I answer for you guys?
How do they evacuate what's in the home?
We basically lift them up and we kind of start scooping them out with tools. We try to preserve the top flap, and we have little scoops that we can use, sterile scoops that we scoop them out with.
And wound wash spray, is that one of the acceptable things
I
besides the
you-
saline? I
think
couldn't
that
remember
your
what
wound
you
wash
had.
spray is probably saline.
Oh, okay.
Yep.
If you're in the home, what do you suggest if we don't have the saline, but we come across somebody that yesterday afternoon we found and they got this god-awful skin tear that they've wrapped up in duct tape and Kleenex. What are the chances, if there is any flap that you can put over, are you gonna run a risk of having infection underneath that flap anyway?
I would recommend just cleaning out as much as you can with soap and water. Yep, and if you can unroll the flap, do. If it's all wadded up and dead, you know, it's purple, it's all wadded up, trim off the dead part. And then, what do you, our bacitracin and Telfa? Because that's something you guys would always have, right?
No,
No?
no. We'd have to maybe see what they have in the cupboard or something, and chances are if it was that bad, we'd of course send them into the doctor, but.
And it only
Yeah.
expired in 2000.
Yeah. Or maybe it's first aid cream, what do we, what's in first
Right,
aid cream?
right, what is first aid cream?
Yeah,
I mean,
exactly.
really. Yeah, so if they don't have really anything, I would try to have them get in to see one of us, but I would just trim off the dead part, try to find some antibiotic cream with some sort of bacitracin or something. But so you guys don't even carry any, like, samples or anything?
Not typically.
Okay.
So what is the risk of having infection, like when you bring the flap over, if it's a wound that's been open for a while, that bacteria has already started, if it hasn't been
It
properly
depends on
cared
how
for?
long it has been open and if they cleaned it at all. If they didn't clean it at all, I would still say just clean out underneath it really good, like a antibacterial soap if you have nothing else. And then put the flap back down. Since it's a flap and not a true like laceration, the risk of infection would be less compared to like that of a laceration that you're suturing closed. Good question, very good question.
Because we do have dressings, I mean, your Telfa is your
Yeah.
4x4 is your clean, but we don't usually typically carry the antibiotics.
Yeah, I should send like some bacitracin and some Zero from gauze or something with you guys. I have little tiny samples.
The tough thing comes is we don't really have an order for it, right?
I can get you a standing order.
I was gonna say, maybe just get a protocol or something.
Yeah, I should get you guys a
Exactly.
protocol. Why don't you guys just have our
Med-surg one
protocol?
and
What's your order?
just use it, yeah.
Yeah.
So our med-surg one says, with the skin tear, we're supposed to put a Metholex on. So these ladies that have that really fragile skin, a Metholex border
Yep,
on that?
yeah, because that's silicone, and so that's actually one of the better ones. That's the silicone, those are very, very gentle to the skin, and those are good, yep.
A lot of people are just afraid they're gonna rip more skin with
Yep.
it being so thin.
No, that one's okay. That one I use on all of my patients is a very, very safe one because it doesn't technically have a true adhesive, it has silicone. And so we still skin prep underneath of it, silicone, and that's what I use on almost all of my super thin, like paper thin patients. I have yet to have a skin tear from use. And I, of course, am very careful about removal, but it doesn't truly have an adhesive property because it has silicone in it. And that's what they recommend is a silicone base.
So that's a Metholex border?
Yep. And they're expensive. So that's why I'd be careful with home health because you guys pay for it on a limited budget. So I would try to figure out what to do with home health. That's tough for you guys.
How long can those be left on?
Up to 7 days or 50%, 50 to 75% strike through.
Can you repeat what you just said, 50 to 70%?
75% strike through. So when you're looking at it on the patient's body and it has like the square pad, if
Okay.
it looks like more than 50 to 75% of it has gotten drainage on it from the underside, then you want to change it.
Okay.
Or I'm gonna increase, it's at 3 days right now, I'm actually gonna increase that to 5 days, or 50 to 75% strike through. So they're recommending it to be left on longer now.
We still see takedowns.
No,
We still see takedowns.
what?
We still see takedowns.
We should be using some takedowns.
We know.
Well, and we have a protocol.
Right.
Tegaderms, actually, they say is the absolute worst thing you can possibly put on. So why are we using tegaderms when we have such a great protocol? That makes 0 sense.
I don't know.
So they're worried about using Metholex borders and they're putting tegaderms?
I don't know, it's been taken or about.
You find them once in a
Yeah,
while.
we see them once in a
They're out there.
while.
Yeah, the International Skin Care, or whatever advisory panel actually talks about how detrimental tegaderms are to skin tears.
So if we see that, let me know so we can investigate where it's coming from. Hopefully after this presentation, whoever's doing it will realize it's wrong.
Yeah, please don't use tegaderms. Now we know. Maybe people just didn't know. I mean, because back in the day, that's what we
Somebody might
did.
have, yeah.
I mean, back in the day.
Yeah.
Randy, was it you?
Randy's kind of red. He is turning kind of red.
Just wanna know where they come from, probably the bedroom.
I know a lot of times we use the, like the Metaport, I call it toilet paper tape, because you can, you know, and that seems to work better than
Oh,
regular.
yeah, and so if I ever use tape, that's what I do use, but I try not to use it at all. I do use that on some of my elderly patients with a whole heck of a lot of skin prep. But not the ones that are tearing frequently, yeah.
So what does that skin prep do exactly?
Basically, it makes another layer between your patient and their skin, or between the product, whatever you're sticking on, the bandage, and their skin. It basically makes another layer. So occasionally I might put it on, let it dry, and then get out another one and put it on, let it dry. On the really bad patients, I'll put it on, and then I'll put a layer of nystatin powder, and then I'll put a layer of the skin prep, and then a layer of the nystatin powder, and it creates like an actual full extra layer of whatever barrier, and then use that. It's basically like a second skin. Any other questions?
Thank you.
Yeah.
Thank you very much.
So what is in front of you, Michelle talked about the skin tear, so we already have like the protocol for what to do with the skin tear, but we never had anything for how to prevent them. So what you have in front of you is the prevention part. And what we hope to do is, like Michelle said, prevent them in the first place, so we're not having to deal with them. There's gonna be a section, and I kind of wanted you guys' input, so that we can track this and look at, you know, how many people do we have that actually have fragile skin, that we're sending back out of our facility that have not sustained a skin tear versus how many, got a skin tear, so we can kind of track that. But there, will be a flow sheet, and it kind of goes along with the fall risk assessment. So I didn't know if you guys want us to put this with that, so that you only have one flow sheet to do when we admit a patient, versus do you want one that says fall risk assessment and one that is like skin integrity assessment? That's kind of up to you guys how many. It's gonna make the fall risk a little bit longer, but you're gonna be doing all of it anyway.
I'd rather have it all on one.
On one. Okay. And then the other part with that, this is a lot of the things that Michelle presented on the slide, for prevention, you know, like using the skin prep, if we do have to use some type of adhesive on the patient. It talks a lot about padding the furniture, you know, if you're moving somebody from the bed to the commode or to the wheelchair, if they have really fragile skin, use a bath blanket or use towels to pad those edges so that you're providing a little extra layer of protection. When we visited with the nursing homes, Quality visited with the nursing homes about what they do to help prevent skin tears. And one of the things they do that we have not been doing is that they use sleeves for the patient. So it's just the jersey stockinette. So I went and snooped around down in ER and I thought, yep, I think that'll work on med-surg. So it's literally what you put on like before you do a cast. So what we're gonna do is anybody that has, is at risk for skin integrity breakdown according to your flow sheet when you do that. And I think it's pretty self-explanatory. The first section, if it's a yes to either one of those questions, they're at high risk. If you do the next section, I think if it's 4 or more, they're at risk. The third section is 5 or more. Or if you have 3 or more in either of section 2 or 3, they would be considered high risk. So those are the people that we want to be padding the furniture as we're moving them so that we don't, you know, accidentally bump them and cause a skin tear. We can hopefully prevent some of those. And the other thing is to cut a piece of the stockinette, so it just provides an extra layer of protection. If they're at home, you know, encourage them to wear long sleeves, wear long pants. It just provides that little extra bit that might help. So you can just cut to the length of their arm. You know, if it's somebody, we talked about the top of their hand as well. You might be able to do like a sleeve. It just kind of depends on the person. You could add some length there and cut a thumb hole, that type of thing. I tried it out this morning. It keeps you nice and warm, so if anybody's complaining they're cold, you can do that. You know, you might have to be kind of careful or maybe improvise if they've got an IV site that we need to watch or that kind of thing as well. So, you know, you might have to improvise a little bit. They have bigger sizes down in supply, so if you have somebody that we want to do their shin, you know, and cover as well, that they're getting up and out of bed and we have a risk that we might bump them, we can get a bigger size, so we can do that on their lower extremities as well. So those are just a couple other things that we want to try and do to help prevent it in the first place. Any questions about any of that? Jill has not gotten, as far as I know, this flow sheet built at all. So if you guys think you want to have it put in with the fall risk assessment, I'll have her do that. And then I'll send out an email and put up a note when we're ready to go with that part. The policies for nursing and med-surg will be updated, I think the 22nd of October. So any of the changes, she talked about a few things that are new in there, those will be presented and approved at that time, so those will come out as well. And that's all I got, unless you guys have any other questions. Thank you very much for coming this afternoon. So, and we'll put the stockinette in with the surgical